The information in this broadcast is for educational purposes only and is not provided as a professional service, medical advice, or is it intended or implied to be a substitute for diagnosis or treatment. You are encouraged to confirm any information obtained from this broadcast with other sources and review all information regarding any medical condition or treatment with your physician and other appropriate healthcare providers.
Hi, I'm Pete Levine. Welcome to Noggins and Neurons, Stroke and TBI Recovery Simplified. I'm a clinical instructor and clinical researcher. I've co-authored dozens of scientific journal articles about brain injury recovery, and I'm also the author of the book Stronger After Stroke.
I'm Deborah Battistella, occupational therapist, creator of the OT's Guide to Mirror Therapy, and an OT educator. I have a lot of experience working with survivors. Most of my clinical practice has been in a certified stroke center. Pete and I are especially interested in talking about what rehab, neuroscience, and clinical research all have to say about the brain and recovery. But don't worry, our job is to make this stuff simple.
We're here to make it so that everyone, clinicians, clinical students, caregivers, and most importantly, the survivor, understands what it takes to leverage their great neuroplastic brain for recovery.
This podcast began with both Pete and I, two kindred souls with a passion for moving the recovery process forward. If you've started listening more recently, say since the beginning of 2022, you likely noticed that Pete is absent from conversations. This is because he had a rather unexpected and abrupt departure from this earthly plane. Pete's voice remains in the intro in reverence to and respect for his part of our joint vision for this project. Simply put, it wouldn't be where it is today, nor have a future without him. Now, on to another great conversation. Hello and welcome to the last episode of Noggins and Neurons for 2022. We're saying goodbye to this year and welcoming 2023 with Suzanne Briggs, an occupational therapist from Colorado Springs, Colorado, certified in Remedial Vision. Suzanne works with stroke and brain injury survivors in a hospital outpatient clinic in her town. She is currently finishing up her Doctor of Occupational Therapy capstone project, and in her spare time, she enjoys guest lecturing and presenting to her local brain injury and stroke support groups. She shares her expertise and explains things in ways everyone can understand and follow. You're in for a real treat. These next two episodes are so full of valuable information that if you're anything like Doro and me, you'll want to take notes. Before we continue on, Doro and I wish to express our deep appreciation to all of you for being here on this journey with us. We've had a steep learning curve this past year and are so thankful for your dedication in listening and sharing the podcast with others you know will benefit from it. Thank you. If you want to learn more about Doro's services, check out theneurohub.com. And if you're interested in mirror therapy client support materials, check out the OT's Guide to Mirror Therapy. Links are in the show notes. And now, here's Suzanne.
All right.
So exciting to have you here, Suzanne.
Thank you. Yeah, I'm excited to talk about what I realize I love, and I didn't realize that until like a year or two ago. So it's kind of fun how I'm 20 some years into this profession, and I'm now finding where my niche is. I'm figuring it out, and it's just kind of happened to not so much fall in my lap because I did search it out, but it's funny how circumstances brought me to a point where I just kept going down that rabbit hole, and the rabbit hole got deeper and wider.
So you're very interested in vision rehab.
Visions, and more to the point of remedial vision
Okay.
versus low vision. And there is a difference.
Yes. And I want to talk about the difference at some point, probably
Yes.
sooner rather than later.
Mm-hmm.
I am curious, though, how you decided that this is a passion of yours. Did you have a bunch of clients that had vision struggles or?
Right. Absolutely. That's exactly what it was. People were coming in. So I work in an outpatient clinic, and we focus on, well, OT specifically does neuro, hands, and now vision. But we were seeing a lot of patients coming in with concussion, brain injuries, were the big ones that kind of got me started on this. And sometimes PTs would have patients with vestibular diagnosis, and then they would slide over to OT because maybe what they were doing wasn't hitting everything, and there were still symptoms and they couldn't figure out what was going on. So they'd slide them over to OT to see if we could figure out if it was a visual perception thing. Well, as I started thinking about some of these patients that were coming, they would go see an optometrist, and there were a couple of optometrists in town here that were familiar with us, and we knew them as neuro-optometrists. And so we would refer them to the neuro-optometrist, and the neuro-optometrist would say, hey, we have this therapy program that you can participate in, but it's going to cost so many dollars. And a lot of our patients, they're on Medicaid, and so they cannot afford private pay anything. And so I felt like there was a real lack in the community support for them. And then they just had this big need to have that vision therapy service get provided. And who better to provide them provide vision therapy to them but OTs. So I started looking into it. I would go to these neuro-optometrist offices, and I'd call them up and I'd say, hey, I have a patient coming. Can I just come in while my patient's there and kind of shadow what you're doing? And so it kind of started from there. And then, hey, that's a really cool thing. Can you come and can you talk about that in our clinic? And then sometimes they would come and kind of describe what they're doing and why we need to collaborate with them and what we can do to help those patients. So they kind of gave us a few treatment ideas. Great. Loved it. But it wasn't enough. I wanted to know why. I wanted to know how. I wanted to know why prisms, why lenses, why was it those things that helped those patients? So I kept calling the doctors and kept saying, hey, I have some free time. I'm not working this day. Can I come in for a couple of hours? And they were super nice. This is before COVID, like right on the front end of COVID. So they're like, yeah, come on in. No big deal. I'll tell you what I can. And so just befriended the neuro-optometrists, and they kind of helped me understand a few things. And then I realized, okay, there's more to this, and I can give this an OT spin. And I can make the OT Practice Act work with what optometrists are doing. Now, keep in mind, I knew I couldn't do prisms. I knew I couldn't do lenses. I can't prescribe anything. I know that. I can't diagnose anything. I know that. But those treatment ideas that they gave me, how can I add function to it? What can I do with function with those treatment ideas? So I dabbled with that a little bit, played around with it, and it was a lot of fun. And then I'm realizing that that's not enough. There's more to it. What is it? Like, yeah, I'm giving them these treatments, but what is the why behind it? And why, like, how is it working? What is the component in the brain that's really working to make this a treatment that I can get behind? Because I want it to be evidence-based, right? So I started just doing continuing education. The big one that I went to was Robert Constantine. He's a big OT that collaborates with OD, which is optometrist. So he has a lot of continuing education on how OTs can play a role in collaborating with optometrists and what treatments can OTs have within that realm of vision, remedial vision. So I loved it, wasn't enough, wanted more. I started searching optometry world. And so I started looking at, okay, if I want to know more, OTs don't really teach this stuff. Who teaches it? Optometrists teach it. I found Dr. Mitch Scheiman had done in the past continuing education for therapists. So I kind of reached out to him and he says, there's actually the optometry school, Salus University, is now pairing up with OTs. And so they're doing like a collaboration of optometrists and OTs. And I'm teaching this class to OTs, the same information I teach my optometrists on what you need to do to get these eyes working together and he says, and we put in that OT twist where it is function with that. I'm like, great, that sounds like what I need, sign me up. So then I got Remedial Vision certified. And then I realized, gosh, I'm only I've already completed half of my doctorate's degree. So here I am now, finishing my doctorate's degree, figuring out my research, and I should hopefully be done with all of it at the end of May. But in the meantime, I'm kind of developing this vision program. I am collaborating with the area's neurooptometrists and just growing and just loving what I can do with vision and how it can really add to my occupational therapy treatments. And then to that point, not only am I doing that, I should back up a little bit. A lot of what this remedial vision in adults is for people with brain injuries. So we're talking concussions, TBI, like mild, moderate, severe TBIs, and then strokes. Those are going to be the biggest people that I'm going to see. And then there's also the pediatric side. And my clinic is all adults for the most part, unless there is a child that comes in with a concussion, then I can treat them too and use the same treatments with them. So,
oh my gosh. I just have to say, I am so stinking excited to talk to you. You don't even understand. I have so many clients in neuro that come in and the caregiver goes, oh, I think it's a cognitive issue. Yeah. And then I ask him, has anybody checked their eyes? Do you feel different since you had your stroke? No, I'm normal. Vision is fine. And then we check it and we find they have a field cut or visual neglect, anything that they had no idea they had. And they just miss half the world. So it has nothing to do with the cognition. It's all vision. Right. They just missed the information. And it's so needed to spread the word that clinicians get more comfortable, especially PTs and OTs. I feel like we're the first people in touch with the clients in the inpatient, outpatient setting that can address these issues better. So I just think it's super important to just spread the word and share the knowledge.
Because if you know how to screen for, then you're getting those patients up and going a lot faster. That neuroplasticity can kick in. And of course, you got to wait for the brain to heal and be ready for that, right?
Right.
But you can I feel like the sooner you can start with that vision component, just like after a stroke with your arm, you want to get started with that sooner than later to get that neuroplasticity to kick in sooner than later, right? So remedial vision there's different layers to vision. The first layer is your eyes need to see clearly. So you need the optometrist to see these patients right off, to make sure they have the right prescription, make sure that their eyes are aligned. And if they aren't aligned, they're going to need prisms, or if they need help with alignment, they're going to need prisms. And you got to make sure that their eye health is well. So we always have to be working in collaboration with the optometrist. And I do want to make sure that people understand that is part of my treatment, is getting the optometrist involved. The next step is where therapy happens. And that is when your eyes you have poor eye movement, which would be your saccades or your pursuits. You have binocular issues as far as like eye alignment, and that can be aphoria or tropia. And then also accommodation also goes in there. And those are the biggest areas that I do my remedial vision with are those areas, because that's the binocular component of our vision that requires neuromuscular control. And so that's what I tap into. I tap into that neuromuscular control, teaching them how to engage that control as they're moving their eyes, either teaming them together or jumping with saccadic eye movement or pursuits as you're following or tracking something.
How soon? Sorry, am I cutting you off?
No.
Okay. How soon after the injury do you get started with the therapy, the vision therapy? Because when we screen clients in outpatient, a lot of them had their strokes several years back. But then we had fresher strokes that were less than 6 months. And we tried to work with an optometrist, and we always get the same answer of give it 6 months. Let the brain heal, let the swelling go down. Before then, there's no point in doing anything. Have you found the same to be true, or would you say jump on it right away?
So I think that there is a bit of a dilemma in the community. I mean, in just the worlds, like the neurologist world, optometrist world, and whether that optometrist is a neuro-optometrist who understands how the brain works with the eyes versus just are the eyes seeing clearly. So sometimes that's also a difference of understanding. I have not had any pushback. In fact, we have in our hospital, we have a neuro-optometrist that goes up to inpatient. So we're talking like a week after a stroke, and is teaching therapists what they need to do for their remedial vision.
Oh, wow.
So
that's incredible.
Yeah.
Yeah.
That's progressive.
It really is. And the fact that they recognize that therapy has a huge role in helping this patient is also wonderful, that there isn't that turf war, and because that can happen so easily.
Yes, it sure can.
So I'm trying to think, I wanted to talk about what it was that I did with the like what it is that I'm looking for. And so when people come to me, I'm looking at binocular vision. I'm looking at how are the brain using both eyes together? How are they processing that vision? So I'm working on that neuromuscular control. And then that next level, then
before you go to before you go to the next level, and can you talk a little bit about how does a person present if they're having a challenge with the binocular vision? Just for people who are survivors and care partners to understand, because I know sometimes we've already talked about the presentation can be difficult to pick up on because people do think there's a cognitive problem at times.
Right.
And so I want to make sure that we don't get too far into it and lose people who really need to hear this.
Right. So for and I'm talking specifically for TBI patients, and some of these symptoms bleed over to stroke, but a lot of these are TBI, and I'm trying to find the quote that I have here. It's from research. Here it is. It's from research 2021. It says 46% of TBI survivors have visual field deficits. 40 to 48% have convergence insufficiencies. 31 to 47 have accommodative insufficiencies. 6 to 9% have diplopia, which is double vision. 10 to 30% have ocular motor deficits, which would be your pursuits and saccades. So that is kind of what we would typically see with TBI.
So now, if somebody has a problem with accommodation, is that going to look like anything?
So that's going to be somebody who says, gosh, I can't get anything to be clear. Accommodation gives us clear vision. Accommodation and convergence of your eyes work together. When your eyes move in just the right amount, there's a reflex system that tells your lenses to change its shape. And so the muscles around the lenses pull on that lens to change its shape, and it makes that image become clear. So your eye has to see the image clearly. If it doesn't, it's telling your brain, I don't see it clearly. That accommodation or that lens starts to change its shape, and it allows for that image to become clear. If you can't do that on its own, then you would need some glasses to help you. So after 40, a lot of us need that help. So accommodation means clear vision.
Okay.
Those two work hand in hand.
So sometimes if people wore glasses before their injury and accommodation is a challenge, they would know if they put their glasses on and they still couldn't see.
Yeah, they would have a hard time maybe, or they would have, and maybe they could see, but it would take them a lot of struggle to see with their, or sometimes you might see where if you're a kid in school and you're taking notes and you look up at the board and, oh, it takes a while and there, now I can see. And then you figure out what you got to write down and you look down at your paper and, oh, it takes a while and there, now I can write it down because now I can see with a line. Yeah. So that would be,
I can see where that would be exhausting.
Yeah. It takes up a lot of brain work. And so vision leads, and one of the neurooptometrists here, that's his line that he tells everybody. Vision leads. You walk into a room, it's your eyes that tell you where you are in space, what's in front of you, how far away is it from you, is it moving, do you have to move? And so that spatial awareness is like your magnocellular tract. And when you say, oh, that's a chair, oh, that's Susie, or that's purple, that's your parvocellular tract. So your brain starts processing that, and it just starts firing up your brain. So vision leads. If you don't have your vision, it's hard to know where you are spatially and who and what and any descriptive nouns around you. Yeah.
Okay.
So that's
Thank
a cognition piece, right? Yeah.
Well, thank you for making that a little more clear.
Yeah.
So that's a solid foundation, right?
Say that again. It's a solid foundation.
Yeah.
Like creating. It's a known.
If it's intact, there's a good foundation to start from. If it's not, but there's still more, because you said it's hierarchical. Yeah.
There's level two. Level two. Okay. So level one is, are you seeing things? Is the image clear? Right. So do you need prisms? Do you need lenses? Is your eye healthy? Do you have macular degeneration? Do you have cataracts? That sort of, do you have a detached retina? Be figured out first. Level two then is where I can start coming in and working with binocular vision, eye movements, eye alignment, that sort of thing. Level three then is so we're working on that hierarchical, that was a mouthful, layering, right? So once we start getting your eyes and your brain working together, and your eyes are working together, your brain is using your eyes appropriately, then we can start getting into the higher level, which is visual information processing. And that is where we tap into a lot of, we'd be using tests like the MVPT test. I forget right now what the pediatric one would be for that. The berry, anyway. Yeah, so we would be tapping into those sort of higher level information processing. So like the figure ground, the spatial orientation, the figure closure, the
visual memory.
Yes. All of that, right? And there's that cognitive component that goes along with all that too, right? So yeah. How can we expect our brains to interpret what we're seeing if we're not using our eyes very efficiently? If we can't get it to be a single picture, or if we are having a hard time seeing things clearly, well, then that brain is already kind of foggy, kind of sluggish after the injury. Then it really is harder if we're not using the eyes efficiently. Yeah.
Yeah.
So kind of adding on to that, then you've got, like, if you have a brain injury, then you've got like all the vestibular stuff that can go and make everything more haywire. And then you could have sometimes a midline shift that happens after. So all of those things is so vision related. Yeah, there's so many different.
You really can't take vision out of the whole process. And I wonder sometimes how much that gets missed. I mean, Doro, you already mentioned it.
I think it gets missed a lot. And I'm totally honest, when I worked in an outpatient setting before I did driving rehab, it was something that I frequently overlooked. You know, you just check briefly, saccades, okay, convergence, okay, peripheral vision maybe, and that was it. I didn't really put a whole lot of weight in it. I was more concerned about arm movement, arm weakness, that sensory issues, but not the vision. And then once I started the driving rehab,
A lot of vision. There's a lot of people that sometimes even have a slight midline shift that even the neurologist is going to miss because it's so slight. But when people start saying, I'm having a really hard time parking in the lines, or my arm I'm always bumping into this one side of my body, or and it's
when they ride on the divider line and it goes cluck clunk cluck clunk cluck clunk cluck clunk, you ask him, do you think something's going on? He's like, no, I hear something clunking.
Is your van okay?
Yeah, the van's fine. But yeah, it's so interesting, and it's
right.
We need more of it.
I feel fortunate because I always say the clinic I grew up in, it's the clinic I worked in for a long time, and it was a certified stroke center, and we had a neuro-optometrist that we were regularly interacting with. So I feel like I've been fortunate that way. Not that I am near at your level, Suzanne, at understanding all of this, but at least I had an awareness of it and could identify if there was something going on and refer to the neuro-optometrist.
Yeah,
but we did not have that
him.
person. Yeah, but we didn't have that person come in and work with people. That's awesome.
Right.
That's a gift.
Right. Yeah, for sure. Yeah, and I love the fact that the more collaboration you can do, it's just,
oh my God,
it's better for your patients. You're going to be able to see the patient from different views and and
angles.
You're going to have the patients love you more because they know that you're talking to their doctor, and they don't have to remember everything. And there's so many times the patient will go to the doctor and they'll come back and they'll say, I don't know what she was talking about, but here's my prescription. Tell me what it is. And so I can read the prescription. I can tell them, you have prisms and this is where it's based out here because of this reason. And this is why she put it that way. And this is, and so I can talk to them about that. And the doctor and I are also like faxing notes back and forth too. So I also have their notes. So I know what she found and what her thoughts are, or I shouldn't say her, him. So I love having that relationship where I can just quick text the doctor saying, I have so-and-so here in my clinic. Here's a question. And then they'll text me back real quick.
That's awesome.
Yeah. So, and I'm not saying that happens for everybody, every doctor. Yeah. There's just, you start to get a relationship with a couple people and you can really work with that person well. Yeah.
Yeah. So I just wonder, can we talk a little bit about the prisms? Because not everybody understands what prisms are and what they're for.
Sure. They can be for different things.
Fantastic.
How about that?
Can we talk about some of the different things?
Absolutely.
Cool.
Sorry, I'm trying to find, I closed your picture out. Okay.
What?
Prisms, they can be used for treatment, as far as just making that neuroplasticity really kick in and increasing a challenge. They can be used for compensation. So if there is somebody whose eyes aren't aligned and they don't have a neuromuscular component, or they don't have enough let's say neuromuscular strength to hold their eyes in alignment, they're going to need a prism to help them with daily life. If it's atropia, you can see that eye not aligned. If it's aphoria, they can hold their eyes in just enough, but they're struggling. And so they need a prism to kind of help them stop the struggle, start working on that neuromuscular control, and really start to improve that binocular vision efficiency. So then that prism starts getting reduced, and that as they get better control of that system. So, but if you have somebody who has a midline shift, well, then those prisms can be used to kind of pull their spatial awareness or their center of gravity awareness back into true midline with just your eyes being pulled over with the prisms. If you have a field cut, sometimes if it's small enough, you can have a prism help pull what is missing and skew it in front of you a little bit more. So the prism, the thicker part of the prism, there's a thick end and there's a small end, and the thick end is called the base and the small or thin end is called the apex. So when that image comes into that prism, it's going to shift over to the apex, over to the thin end of the prism. So when you have a patient that is base out right, that means the thick part is going to be to the right, and that image coming in is going to be shifted over to the apex, to the inside, to the nasal, to the midline. Okay, so you have neurooptometrists. Some of them can be called behavioral neurooptometrists because they like to see, how does the body react to the prisms? How do they walk before? How do they walk after? And they really use those prisms to change the function of the walk, the gait, the perception, and all of that. And then you have the neurooptometrist that might look at use those prisms more for eye alignment, if that makes sense. And a lot of times it's like you get one, you get the other one. So they just don't look at the whole. Not everybody does. But the behavioral optometrists are going to really hone in on, how does that affect your body? How does that affect your movement?
So to say it in really simple terms, a prism is glasses, correct? Where the glass is cut in a manner that it compensates for the area of weakness. It basically picks
so the
up
prism is
that
called
area of
ground
weakness.
in, or it can be stuck on.
Mm-hmm.
A field expansion,
Okay, so it's
or it can be like a sticker
in the
put
glasses, right?
Yeah, depending on their need,
okay.
and depending on they're called field expansions, or they're Peli prism expansions. There's a couple of different ones. So yeah, but yeah, otherwise they're ground into your lenses. They're expensive, and so especially when you have somebody who starts out with like maybe a 5 prism diopter prism that's fairly thick, and then that prism no longer works for them because the efficiency of the brain is kicking in as you're working with it. And then that prism has to go down a few more prism diopters, and then they have to get a whole new set of glasses. And so it can be very expensive. And so which is another reason why I'm like, the faster I can get these people starting to engage that neuroplasticity, start engaging that neuromuscular control of that eye efficiency, then the less they're going to need those prisms if they needed them to begin with. Hopefully. I can't say that's, but that is like one of my arguments to the doctors is like, you want me in there sooner than later because you want these people compliant with their prism glasses. There's so many patients that come to me and they're like, it was going to cost me $500-$800 for these prisms. I'm not going to take it. I'm not going to do it. And then I'm like, I want them to get the best results, but I totally understand that money, that price point is tough for some people. So then we look at community support and try to get a scholarship for them or something like that for those people that can't afford it. in our community, Brain Alliance is a great community resource that you can apply, and they can help you out. Yeah.
If somebody ends up, you know how sometimes people have a brain injury and they switch from traditional insurance to the Medicaid waiver program. Do you have that where you are? How does that work for being able to get the proper vision supports?
It's hard.
Does that make it a little more difficult?
Yeah. And that seemed to be like the big hole in service in our community, was just like, these people don't have a job anymore, or maybe they didn't have a job to begin with and they were in a car accident, or, just that seemed to be the population that was falling through the cracks. So, and since we can bill Medicaid for our services, I'm like, this just seemed like a win-win for everybody, because now they can get the remedial vision help that they need, and maybe not spend money on that rehab part of it if they need to spend money on their glasses part of it.
Yeah. You know how you can donate your used glasses to the Lions Club? Can you donate
prism glasses
that don't work for you anymore? Can you, I wonder if there's that would be able to reuse those.
Yeah, I wonder. I don't know, because prisms are ground in to the regular prescription, right? So I don't know.
Maybe that's why the stickers are a good option.
Yeah, maybe. Sometimes the bad thing about the stickers is that you can kind of see the lines, the prism lines on the stickers. And sometimes after a brain injury, you have a hard time. It's like looking at the windshield or looking through the windshield, looking at the window and seeing the spots, or looking through the window. And sometimes it's hard to not see the spots on the window. And that is really hard.
Yeah.
For some people. So
that makes sense.
Yeah, that makes sense. I am incredibly curious to learn what a treatment session looks like.
Yes. Okay. It all depends on the diagnosis.
Well,
yeah, right.
One.
Okay. So let's say, since convergence insufficiency is kind of one of the more common ones, and you can have this after stroke, you can have this after TBI. First, how am I going to know someone that has convergence insufficiency, right? I have this it's called the OMAT, Ocular Motor Assessment Tool. And I'll kind of show you a picture. That's kind of the tool that I use and do a lot of my assessments with. But if you don't have that, you just take a pencil and a tape measure, and you don't measure to the tip of the nose. You measure to the top of your nose in between your eyes, because that's going to be your consistent measurement. Everybody's got a different length of their nose, so you're never going to have a consistent measurement there. Yeah.
Yep, makes sense.
So that's like one of the first things I tell everybody. Don't measure to the nose. So you're going to take that pencil and you're going to bring it, and you're going to watch their eyes, and you're going to see at what point, and you're going to ask them, tell me when this is double. I don't care if it's blurry. You tell me when it turns into 2. And when they say it turns into 2, you see, and there's also a difference in the optometry world versus the therapy world. What is normal? A lot of the therapy world will say 10 centimeters. The optometrists that I work with say closer to 5 centimeters is what they would want. And some of that also has to do with age. You're not going to require a 90-year-old to be 5 centimeters, But so yeah, you're going to measure it to right here between the eyes above their nose. And when they say it's double, or when you see an eye slough off, or when you see your eyes kind of jump back and forth, that's where you stop. That's where you measure it. And if it's not within normal limits, then they might have convergence insufficiency. Who can diagnose that? Not me. I can't diagnose it. All I can say is you have the symptoms that are similar to convergence
Consistent
insufficiency.
with.
Go see a neurooptometrist, get diagnosed, right? And then I have them fill out a questionnaire. It's called the Convergence Insufficiency Symptom Survey. If that score is above 20, that means that they are more than likely on the side of convergence insufficiency. So then I also do a test where I have them go near, far, near, far, near, and see how many times they can do it. And then there's norms to what's normal. But for anybody who wants to look at their patient and say, I wonder if there's convergent, like any PT, any speech therapist that's out there, they want to know, that is the way I would have them do it, is just take that tape measure with a pencil, stick, whatever, and see where they can go before their eye starts doing funny things or before they start seeing double. Then we start working on that neuromuscular control. And maybe one of the first things I have them go home with is a Briggs string. So there have been studies out there now that have shown that pencil push-ups are as good as placebo. So if you want to give your patient something to do, sure, you can give them pencil push-ups, but you're not training them any neuromuscular control. You're not training them what it is to engage both eyes. All you're doing is just saying, see one? Do you see one? Yeah, they probably do. If one eye's suppressing every time, they're always going to see one. So that's not really helpful to help them understand neuromuscular control and get better efficient binocular vision.
Did you already talk about pencil push-ups when I was gone?
No, I was doing it right now.
Oh, okay.
Don't do it.
I'm not going to do it. But I think people who are listening might want to know, what is a pencil push-up? It's different than a pencil pusher.
Yeah, that's a good question. So it's when you take a pencil and you hold it out in front of you and you look at that pencil and you want to keep it one. You want to keep it one as long as possible, and you're bringing it to your eyes, right? Which is great. But what happens to those people that don't have a hard time controlling their eyes or have suppression, which means one eye is not working? They're always going to see one, and it's going to come right up to, to the bridge of their nose, and it's always going to be one without a problem. And so you're not teaching them any sort of neuromuscular control with a pencil push-up. And so I was just saying that there's research out there now that was able to demonstrate that pencil push-ups had as good of a result as the placebo in a random control study. So for that main reason, where it could maybe work for some, but really it wasn't really training that neuroplasticity part of what you need to really, really work at to get your brain to use your eyes efficiently.
So this is the part that really is what we understand as therapists, that a lot of times survivors and care partners don't understand, right? That neuromuscular control piece. And so what what you're saying is that you're not causing a change within the brain that will cause a change in the way the eyes function with just doing a pencil push-up.
Right. Yes.
So it's not going to hurt anything.
So that's where
Sorry, Doro. But it may not be helping anything.
Right.
Doro.
Thanks. So that's where you use the Briggs string. And could you describe the Briggs string a little bit for our listeners?
Yes.
Because they're probably not familiar with it.
So the Briggs string is a piece of string with beads on it. And depending on, it can be something that you just make at home even. It doesn't have to be specially bought, but depending on if you do want to buy it, you could have 3 beads on it. You could have 4 beads on it. And you're going to tie one end of it to like a drawer pull or a doorknob or an armrest on a chair or the leg of a table, anything. And you're going to pull it tight up to the tip of your nose or even the bridge of your eyes, wherever your bifocals sit, and you're able to look down that rope. And you're probably going to want to use your bifocal part of this, because I'm going to tell that patient, you're only going to pay attention to one bead. Ignore the rest for right now. We're working on that one bead. You're going to bring that bead closer to your nose, and you're going to look at that bead, and that bead needs to stay one. So maybe I'll start them at 10 inches. Maybe I'll start them at 8 inches. Kind of depends on how where that pencil split into two. And that's called a near point convergence. All these big words, right? So I want to remember those PTs out there. And anyway, I will have them look at that one bead. That bead needs to stay single. But as they look at that one bead, I want them to see 2 strings in front of that bead, 2 strings behind that bead. And when they see 2 strings in front and 2 strings in back, that's going to tell them that both eyes are working together. If they only see 1 string, that means one eye's not doing its job.
Oh, okay.
So you can and the goal is to get that bead up to 1 inch away from their nose. That's the big goal. And maintain the 2 strings in front, 2 strings in back. And then I ask them, do you see 2 strings in front, 2 strings in back? Great. What letter of the alphabet is that? Well, it makes an X. So then we start saying, okay, do you see that X? If you don't see the X, then both eyes aren't working together. So then I want them to recognize how it feels. How do your eyes feel when both eyes are working together versus not working together? So then we're getting that kinesthetic awareness, right? We're getting them to really understand how it's supposed to feel when your eyes are getting more efficient, and it doesn't feel good. It hurts. It's a lot of work. But the more efficient they get, the closer that bead can come and maintain that X. And that's where we start. Or home exercises.
So at what point? Okay. So at what point would you add the second and third bead?
I add the second bead when they can get like a few inches from their nose, and then they can start looking away, coming back to that bead and getting it, looking away, coming back to that bead and getting the X. So we're adding that. And then if the patient doesn't have a lot of vestibular issues, I'll even have them start nodding yes, shaking their head no, keeping that X. Okay.
So if they have some vestibular issues, are they going to get a little nauseous?
They could.
Yeah.
Vision therapy is tough. And that's the hard thing about therapy and having people go home and do their exercises, is because it sometimes doesn't help them feel good.
Yeah.
But the more efficient their eyes are working together, the easier it gets and the less symptoms they have. But it's that having to see it to believe it kind of a thing, right? Yeah.
How long do you typically work with a client on one exercise? Do you give them rest breaks in between, or is it a 60-minute session, or do you do maybe, I can't even imagine doing it for an hour. So I would think like maybe a few minutes, and then you give it a rest break and a few more minutes and switch it up.
I tell my patients, even for home exercises, that all they need to do is 15 minutes a day, break it into small chunks, but just 15 minutes. That's really don't overdo it. And we only have 40 minutes to see our patients, so that really limits me. So when I'm doing the Brock string, it's just a review, and it's to set them up to go home and do it. I'm not spending a lot of time with it. They will come back in the clinic. If they still have questions about it, then we'll review it again. But otherwise, it's like they should be able to do it on their own. Until I add that next bead, I'll ask them, how close is that bead to your nose? And then when they're a few inches from their nose, then I'll add that second bead, and then we start doing what's called bug on the string. And that requires a little bit more control of eye alignment to do that. So there is a progression. And so now I'm using 2 beads, and not everybody does it this way. I know, I understand, but if I really want to get to what the patient needs for convergence and sufficiency and that neuromuscular control, those are going to be the 2 big ones that I do with Brock string. And then I use those great 3D looking glasses, and we do what's called vectograms, where we get that 3D effect, really working on convergence and divergence with your eyes aligning to see near, your eyes aligning to see far. And then if there's an eye suppressing, I'm going to use red green glasses also. We're going to work on stuff like that. And then we're once those things start to get under control, then we're using eccentric circles where your eyes have to take two circles and make them into one, and you get a 3D effect with those two circles. But keep in mind, I'm always adding proprioception to it. We're standing, we're walking, we're on foam, we're on tilt boards, we're on balls. I mean, if you're highly symptomatic, we're sitting still. And maybe to start something, we're sitting still. Otherwise, I want you up, I want you moving. I want your eyes getting used to having control with processing peripheral movement, processing any busy background, because that visual hypersensitivity really plays havoc with somebody with a brain injury. So yeah, so those are a few things that I can do. And then I really try to add that, like we go out to the parking lot and I have my patients walking in the parking lot. And when we're working on eye movements, I have them turning their head left and right, because adding that vestibular piece. And we're looking at license plates, and I'm talking to them about needing to be able to look back and forth and making your eyes do most of that work, because your eyes are going to be your faster muscle. They're going to be the ones that see that car backing up in front of you first, and the shopping cart that's in your way, or the pedestrian whatever it is, you need to be able to move your eyes, move your head. And that's one of those activities. And then we go to the pharmacy and we do a shopping activity. Then we go to the gift store, and then we do map reading activity. And then we do, here's the place on the map, now let's go find it activity. And yeah, so I can, I just start layering it up and really having a lot of field trips.
Oh, I love it.
So that's the thing. Like, a lot of people wonder, what is the difference between just going to the optometrist and then working with an occupational therapist, where you're very functional. You're integrating them into the community and forcing their eyes to work so that,
right.
That information can be taken in and processed, and they can get back to life the way that they can enjoy it.
Right. Absolutely. Yeah. And if you're, if you're not an expert in vision, so some of the first things that you can maybe have them do is do eye movement stuff, right? Have them do saccadic eye movements, pursuits. So if you're a PT and you're like, oh, man, I don't know if this patient is vestibular, if it's vision, have them follow a ball, swing a ball in front of them. And if they're like, whoa, that's trippy, or that really makes me nauseous, well then, yeah, there's some vision stuff you have to work on. If they cannot go left to right and go from pencil point to pencil point, left and right, or they undershoot where their eyes can't quite get there, then yeah, there's some eye movement stuff that we have that somebody who works with vision would be able to work on. So those are just some fast things. So like you're working to see how close can that pencil get before it turns double. You're looking to see if they have increased symptoms, or if their eyes have a hard time fixating on a moving object, or if they can jump from one object to another. And those might be some really easy screens that speech therapist, physical therapist, or OT can do to kind of know if there's a vision issue.
Yeah, that's really important, because being able to identify a problem, even if you don't know how to treat it, is going to help the person, because you've identified that there's a problem, and now you can help them decide where to go next.
Right. And PTs are a great referral source for me, because they get a lot of people for vestibular, and then they start to realize that it's not just vestibular, there's other stuff going on. Well, then what do you do? So yeah, there's a couple fast screens that they can know where to go.
Well, can we talk about the vestibulo-ocular reflex a little bit? Because the eyes and the vestibular system are very closely intertwined. They're connected. Yeah.
In the pons. Yep. Yeah. So if your head turns one way, your eyes are going to move the opposite direction, right? And that's kind of called that gaze stabilization. But that's that reflex. When your head turns one direction, your eyes should be able to move the opposite direction, so you can maintain your balance, so you can maintain your position in space. So it is that system that needs to work together so you can turn your head left and right without throwing you off balance and into a wall or whatever, or increase your symptoms of dizziness and nausea and stuff like that. Yeah. So yeah, there's different diagnoses that can affect that vestibular system and affect that reflex. And so
they soak in just sitting in your recliner and watching TV all day. That's not good for the VOR.
It's not good for the VOR at all. No, absolutely not. And I actually just had somebody call me today and say, I've got vertigo. And so I'm asking her all these questions. And I'm like, I think you have crystals, but that's a whole nother podcast.
Yeah.
So
yes. Yeah. Not gem crystals.
No, right. Yeah. Ear canal crystals, which just aren't as fun.
No. Cool.
But we haven't even touched base on stroke yet. I mean, so that's like another category in itself is stroke. And that's what Dora was talking about are these patients with like neglect and field cuts, and depending on where that stroke happened in the brain, where that infarct was, depends on how much of a field cut, where is that field cut versus a neglect.
This wraps up part 1 of Remedial Vision with Suzanne Briggs. Stay tuned for part 2, where we continue learning from Suzanne. Thank you so much for listening to this episode. We appreciate your support and would love to hear from you. Ask us questions and share your thoughts by email at nogginsandneurons@gmail.com. That's noggins, the word and spelled out, neurons@gmail.com. If you like what you heard, please share this podcast with others you think will benefit. Also be sure to subscribe and leave us a review. We'll catch you next time on Noggins and Neurons, Stroke and TBI Recovery Simplified.